Well, good afternoon. Thank you for coming out. I'm Dr. James Conyers, Director of Africana Studies here at Kean University, and once again, it's my pleasure to welcome you to the 2016 Office of Africana Studies Celebration of Africana Studies, which is an annual event that we do every November here at Kean University. It was really started by the late Dr. Barbara Wheeler back in 1987, and I've been fortunate to inherit the ball, and not only inherit the ball, but to make some changes to the ball and to run with the ball. This year, we decided that we would revisit something that we haven't done in many, many, many years, and I think it's apropos that we do that quite often because it's a major problem in our community, the idea of health and wellness. As we walk the streets and as we see who's in the hospitals and for that matter see who's in the prisons and every place else, we know that in our community we have a major problem with mental illness. We have a major problem with biological illnesses, health, the idea of that. There's a great reluctance, and I know our speaker will talk about that, great reluctance among African people going all the way back. I can do a historical thing on this in terms of slavery, but there is a reluctance for a whole lot of reasons among many of us to even see a doctor when we know we're ill. And I would just not say just us, probably in general, but certainly it's probably more grievous among us. Many, many years ago, we had Dr. Barbara Justice here, the famed surgeon from New York, a good friend of mine, and she spoke to these very, very same issues. But we are now blessed today to have a former Kean graduate, a Kean alum, who's come back to Kean and who's going to give us a very, hopefully, very knowledgeable lecture on this idea of health and wellness. So let me just really, really quickly introduce our guest speaker because we want to get right into it and have enough time so that we can have questions and answers and you can weigh in on anything that you have in mind. And it doesn't necessarily even have to be related to health and wellness. You can raise some other issues. I think we're going to have a major problem with health and wellness now that we have a new state of national politics going on, and that has a whole lot to do with mental health and mental awareness. Our guest speaker today is Dr. Muriel Celestine-Raqhael. And notice in both names, both in the Muriel and Raphael names, God is in those names. That's very interesting. The L part, I know for those of you who know that L is a generic terminology for God. You should know that. Those of us who study history know that, like Elohim and other names. So it's very interesting right there. I just thought I'd point that out as an aside for those of you who study ancient religions like I do. So Dr. Muriel Celestine-Raqhael has a BA in biology from Kean College. Now remember, that was Kean College then. We're talking about Kean University now. She attained her medical doctorate from Spartan Health Sciences University, in which she finished her last 2 years in Georgia at Emory-affiliated hospital. She is married to a husband who's also a Kean University alum, and they are the proud parents of 2 boys. Her lecture today is Getting to the Heart of It All. I think it's up on the screen there. Getting to the Heart of It All, Disease States in the African American Community. So please welcome our guest speaker, Dr. Raqhael.
Good afternoon. Thank you so much. It's interesting to hear other people speak about you because it's not necessarily how you look at yourself. I see myself as the mommy that was putting laundry in the wash machine and running out here to do this lecture. So to hear those things, you know, kind of find myself more interesting than I actually am. So thank you so much for the invitation. Thank you to the Department of Africana Studies. Thank you, Dr. Conyers, for inviting me to speak today. It's been a while since I've been on this campus, and if you didn't have the signs, I think I probably would get lost. I would say it's probably been about 10 years since I've been on the campus, and it's greatly changed for the better. Appearance-wise, you know, there's probably still some of the same things going on, and that's why we have people like Dr. Conyers to lead the charge and to make sure that our voices are heard on the campus, as well as the Department of Africana Studies. As it has been mentioned, my name is Dr. Muriel Celestine-Raqhael. I am an MD. I currently work in medical information and auditing. So I help convey new information to pharmaceutical companies and physicians. So I'm probably considered a conduit between the two, because a lot of these companies find that there is a lapse in the way that communication is conveyed to either side. So either the ball is dropped between the physician and the patient, or between the pharmaceutical company and the doctor. And the person that tends to suffer is the patient. I've been translating all my life, so to speak. I like to call myself a translator. I'm a first-generation Haitian American. Any Haitians in the audience? No, not today. Oh, sac passe. I speak French, Creole, and English, and not all of my family spoke English. So we had older people that we needed to speak to, needed to convey information to, and translate, going to the doctor, going to the bank, everything that they needed to do. So you can imagine a little 7 or 8-year-old in the doctor's office trying to explain to her grandmother that she has high blood pressure, that she has diabetes, and then relaying her pains and woes to the doctor to make sure that he's able to get the correct diagnoses. So little did I know that that would help in my future profession. So the way that we're taught things in medical school is not always the way that we're able to supposed to convey it to you, the patient, or to the nurse, or to the farm rep. A lot of things get lost in translation at the hospital, at the pharmacy, and of course with you as the patient. So for example, one thing that we do learn, we learn drugs by their generic names, such as cetirizine, diphenhydramine, acetaminophen, or diazepam. You might recognize some of these names, and most times a lot of people don't. But to a layperson, that's Zyrtec, Benadryl, Tylenol, or Valium. So herein lies one of the disconnects as well. Another disconnect is just how the doctors write. We don't have time to write every single thing about you in your history. So when someone else is looking at the chart, so to speak, a lot of things can be lost in translation. Here's an example. 84F, PT, patient. So we'll just say 84-year-old patient from ED, PMH of COPD, CHF, HTN, DM, AFIB, and PSH of CABG times 4, right KR, left HR, HX of VRE, MRSA. We'll need PICC, CXR, TNC for 2 U's of PRBC stat. Anyone can tell me what I just said? Well, that you can imagine a third-year medical student opening up a chart and being told to present the history on that. So the way to convey that information is, let's just translate that. So that's an 84-year-old female patient from the emergency department. She has a past medical history of chronic obstructive pulmonary disease, cardiac heart failure, hypertension, diabetes mellitus, atrial fibrillation, and past surgical history of coronary artery bypass grafting times 4, right total knee replacement, left total hip replacement, history of vancomycin-resistant enterococcus, methicillin-resistant Staph aureus. We'll need a PICC line, chest x-ray, type and cross for 2 units of packed red blood cells, stat. I'm sure we all know what stat is. So we've heard that in the movies and what have you. So there is the translation. So you can just imagine myself at one of these Emory hospitals picking up one of the charts, 3rd year, oh, please present on this patient, and this is what I saw. So I've learned to break it down into smaller particles of information so that I can understand it, and so that I can also relay the information to my patient. Because when the information is not relayed correctly, you're the one that loses as the patient. And if you don't understand what's going on with your disease state, then you don't know how to best help yourself. You have a question? Oh, okay. All right. So let's continue. So during our time together, I was asked to look at 3 huge medical topics. I'll be giving you a digestible dosage, so to speak, of all of them, and then I'll hit you with some facts of how they relay in our community. These will be called fast facts. I don't really like to do graphs because I don't want you to fall asleep, and I don't want to fall asleep up here. But if you need me to break it down even further, just stop me, and I'll do so. There might be some repetition because you'll find a lot of the disease states run concurrently, and they make you more susceptible to having one or more of the disease states. So today I'll be discussing heart disease, hypertension, and diabetes. All three of these disease states are topics that could possibly take a day or two to speak about in of itself. So we're going to hit some of the more poignant points, so to speak. So let us begin. As Dr. Conyers so beautifully stated, the title of my presentation is Getting to the Heart of It All. We'll be dealing mostly with heart disease in the beginning, so we'll begin right now. So this slide is a slide of the human heart. This is a normal heart. This is just beautiful. This is not what I see on an everyday basis because everyone has some peculiarities, everyone has some irregularities of the heart. So this is just ideal. I'm showing you pictures of the right atrium up top, the left atrium, the right ventricle, and the left ventricle. You also see a beautiful picture of the coronary arteries and the heart in of itself. I showed you this because coronary arteries deliver blood to the heart. And any coronary artery disease is big time trouble because that is the end supply for your heart muscle. If the coronary artery is blocked, then the heart is not receiving oxygen and the heart is not being nourished. The next thing that's going to happen is going to be ischemia, which means that the heart muscle is going to die. When that starts, then hopefully you will have already be seeing someone like myself or you'll be in the emergency department. Simplified circulation. Actually, we're going through the workings of the heart. So we have the aorta, which is the biggest artery in the heart, and there are several branches. You have the ascending aorta, descending aorta, and the abdominal aorta. And a lot of times you'll hear about aneurysms happening, and most times aneurysms happen in those branches. You see the blood vessel at the bottom, and it's with no blockages. You'll see the intima, which is the innermost layer. The media, can everyone see what I'm showing? Okay, the media and the adventitia. Okay, so this is a very simplified way of explaining circulation. Blood gets pumped from the aorta. Then it goes to the arteries, then to the arterioles, which are a smaller set of arteries, then to the capillaries, to the venules, then to the veins, and then back to the heart, and it starts all over. What's remarkable is that the total length of the blood vessels in your body can circle the earth 3 times. So now we're going to go into listing some of the more important and some of the more poignant heart and cardiovascular diseases. Coronary artery disease, that includes your heart attack or your myocardial infarction. Abnormal heart rhythms or arrhythmias. Heart failure, heart valve disease, congenital heart disease, heart muscle disease, also known as cardiomyopathy, pericardial disease, aorta disease, Marfan syndrome, vascular disease, so that's disease of the blood vessel. And so now we'll just go into that list. One of the first ones pictured here is the arrhythmia. And that is just, that can be asymptomatic. A lot of times when people discover they have arrhythmias, might be later on in life if they haven't had any symptoms. They're just getting a regular EKG. So on your EKG, when you're hooked up to the monitors, you'll have this strip come out, and you'll have your PQRST. Those are the readings and those are the peaks. They measure the movement of the blood and the beating. When there is a shift in any of those intervals, P to R, QR to S, S to T, or Q to T, that means there is an arrhythmia. Everyone with me so far? Okay. Heart failure. That's when the heart just cannot pump as well as it should. So your primary symptoms are shortness of breath and swelling of the ankles and feet. This puts a lot of people in the hospital. About 5 million people a year are in the hospital for heart failure. It's the leading cause of hospitalization for people over the age of 65. Heart valve disease. I don't know if I've mentioned those. We have the major valves in the heart, the aortic valve, the mitral valve, the pulmonary valve, and the tricuspid valve. So when these valves are diseased or not working properly, you might be able to hear with a stethoscope. There is an irregularity in the way that the blood is going through different parts of the heart, and the valves are not closing, or there might be leakage, or there's what is called a stenosis, so it's restricted. It moves, but it moves very slowly and is very noisy. Examples of valve disease are mitral and tricuspid valve prolapse. So that means that they tend to stay open. Mitral valve insufficiency, it means it doesn't pump as well as it should. And aortic stenosis, so that's the stiffness. A lot of these arrhythmias you might not see too often, but when you do have patients that come from other countries that suffer from kind of some disease states that we don't see as much over here, you will tend to see them. Congenital heart disease. It's exactly what it says. It just means that you are born with this heart disease. So defects in structures of the heart or the blood vessels. It affects 8 out of 1,000 children. Some asymptomatic, some can cause early death, and some a lot of children can live with, and some people don't even know that they have until much later on when athletes are playing sports. You might have heard of a couple of, I think it was, yes, Dee Brown was another basketball player just running up and down the basketball court and just fell out and died and did not know that he had a congenital heart problem. Cardiomyopathy. So that is a disease state of the output of the heart. So the output is the amount of blood that the heart pumps for a minute. So you have your normal heart, which looks lovely right there. Then you have dilated cardiomyopathy. You can see that the ventricle is enlarged. So that means that your output or your blood flow is going to be decreased, dilated. You see the normal heart here, and you see the hypertrophic cardiomyopathy. Now you can see the enlargement of the heart muscle. So that means that the cardiac output will be high because you have to work harder in order to pump the blood through this enlarged heart muscle. Everyone with me so far? Okay. Would you tell me if you weren't? No, okay, just fine. Okay, pericarditis is the inflammation of the sac that lines the pericardium or the heart. I think Toni Braxton had an episode with pericarditis due to her lupus, which caused her to not be able to compete in Dancing with the Stars. Aorta disease. I showed you the aorta before. This is the normal aorta. This right here is an enlarged aorta, and this is a ticking time bomb, so to speak, because if whatever in here gets loose and causes a blockage, then you're going to have an aneurysm. And if you're one of the blessed few, you will survive an aneurysm. If you're not, then the worst case scenario does happen to take place. Aortic dissection is right here, and that's something that you find in Marfan syndrome, which I'll speak to in a little bit. And aortic disease should be followed. You should be followed very closely by your cardiologist, and they should recommend you to a cardiothoracic surgeon. So we're going to go into atherosclerosis. You're going to have to excuse me, the accent gets in the way here. This is the normal artery. As you can see, the blood will be able to travel through here with no problem. This right here is the artery wall. Like I said, this is normal blood flow. And this is a cross-section of the normal artery. Do we have any bio majors here? Okay. So this should be easy. You should be up here doing this for me. Artery cross-section. So in B, you see the narrowing of the artery. You see the buildup of the plaque. which is the cholesterol, which is all that tasty stuff that you guys are going to be eating Thanksgiving, all them collard greens, ham hocks, chitlins, all that stuff, with all that lovely salt and grease, was it fat back, all that. This is what it causes in excess. So then you can see that it narrows the artery. So then causes it to be difficult for the blood to get through. So your heart has to work harder, doing something that it was normally able to do. So we see the cross-section of the narrowed artery. This is another cross-section. Look how beautiful this is, the normal artery. I would say this would be a baby's artery, but now we're finding children born with atherosclerosis as well. So here's mild atherosclerosis, and this is severe atherosclerosis. So you can imagine your heart trying to get blood, or the vessels trying to push blood down this small little opening as opposed to this. Yes? You don't really want them to become unclogged by themselves. So that's why you really want to follow with a cardiothoracic surgeon and a cardiologist. I mean, it's never too late for healthier eating habits. That'll contribute, but you probably will have to go on medication. Mm-hmm. Sure. Mm-hmm. No, no, no.
So all of these advertisements that we see in newspapers and TV about unclogging your arteries, take a particular pill, or even the idea of, I'm not sure about this, but even the idea of fish oil for a healthy cause. Are those things relevant? I mean, in terms of having a healthy lifestyle, they can be relevant, but do they really do something in terms of these conditions?
Well, it depends on what point in time you start to use these things. If we're talking like over here, it's not going to be as helpful. If we're speaking over here, then we're talking preventive. See, we have to shift our mindsets, and the doctors have to shift our mindsets into practicing preventive measures. Because when we get here, this is a whole different story as opposed to if you had seen me here, if that helps. Yes. Oh, Any? Yes. Unclog, cabbage, the stents, operation, medication, which is what you want to ultimately prevent. So if you have a good relationship with a doctor and good diet, exercise, we'll try to, the most with age, you only want to see maybe this, because some things you can't, prevent, especially if it's in your genetic makeup. But this right here, this is a combination of everything gone wrong. Anyone else? Yes. Yes, I'm getting to that. Okay, I told you should have been up here. You better hire him for the next talk. Okay, in order to best understand this, like I said, we need to talk about cholesterol. So there are 4 different types. Let's see. We'll be talking about that. So this is just showing the blood flow right here. Nice, and that's where you get the nice shushing sound when you're listening to the heart. This right here is some of the buildup, and this right here is the plaque buildup along with the white blood cells and the RBCs that are not able to make it through, so they then start dying here and contributing to the buildup. So these red blood cells are in essence stuck. Everyone can still hear me, right? Okay. So that can ultimately lead to a heart attack, stroke, and pain from lack of oxygen called angina. To answer your question, the types of cholesterol that we're dealing with. Low density lipoprotein equals bad, 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 bad cholesterol. High density lipoprotein, good. This is what we want to see right here. We want to see an increase of these. We want to see very low numbers of very low VLDLs and LDLs right here. They contribute to the buildup, if that answers your question. And the triglycerides, which are fatty acids. Factors affecting your cholesterol: your diet, your weight, exercise, age and gender, diabetes. If you have diabetes, you might end up having hypercholesterolemia and vice versa. Genetics. How much cholesterol is too much? I don't even, sometimes the first number that you speak to someone or say to someone is the only number that they remember. So if anything, this is what I want you to remember. Less than 200. Less than 200 is what you want your cholesterol to be at. That's it. Less than 200. None of these other numbers. We don't want to strive for borderline high. We want to strive for less than 200 for optimal.
What will be milliliters?
Mm-hmm.
Okay. Well, go ahead. If you need it, I was gonna.
That'd be milligrams per deciliters.
Okay.
Mm-hmm.
Just reaching.
Okay. Recommended HDL, good cholesterol levels. As we can see here, for men, less than 40 milligrams per deciliter. 50 for women. Such LDL cholesterol levels are major risk for a heart attack. So 60 and above is what we're striving for. These are optimal levels, 60 milligrams per deciliter and above. So remember 200 and 60, but separately, not 260. Recommended LDLs. You cannot not have LDLs because we eat and we consume things and because of genetics and what have you. So this is where you want to be. This is near optimal, 100 to 129. Anything higher is no good. I don't even speak about borderline high because borderline high suddenly becomes high and next thing you know, very high. And then I find when I tell my patients, oh, you're borderline, then they just relax. They take a pause. They're like, okay, well, then I still have time to eat, some more fried chicken, some more, whatever else it is, McDonald's and Burger King in excess. I'm not going to bash these foods and say that you can't eat them at all. You have to eat everything in moderation. Plaque attacks, how plaques in your arteries affect your body. The problem with plaques is that, as I said here, they remain asymptomatic until they break off. And that's when you'll have your problem. That's when you'll have your sudden rupture, your blood clot, which forms in your arteries, complete blockage of the artery, which leads to stroke or heart attack. And sometimes people are walking around with some plaques in their arteries and they don't even know it. They have like chest pains from time to time. Oh yeah, I just drink some water and it goes away, or I just take some Tylenol. Chest pains are something very, very serious. So if you're feeling like very winded going up the stairs and then your chest starts to tighten or hurt, you need to call the doctor. You need to see a doctor. Everyone should see their doctor at least once a year anyway for your physical. You should have a personal relationship with your physician that understands your makeup, understands your family history, and is someone that you're able to speak to. And don't be scared to ask questions. And if a doctor is speaking to you quickly and is trying to rush out of the room, tell them, excuse me, hold up, my insurance is paying for this. So there's a few questions I'd like for you to answer. I have a few concerns, blah, blah, blah. And if they still are not, meeting the requirements that you need them to meet, change doctors. Yes.
I was going to say, in terms of when you go for a physical, do they usually see that from the blood work?
Yes.
Okay. So they would see that. That's like part of the standard, and they should let you know if
Yes.
Okay.
Good question. Diseases caused by atherosclerosis. Oh, you have a question?
Yes.
Yes.
What is calcium in the heart? Having too much calcium.
Having too much calcium in the heart?
Yeah.
It's a cardioprotective measure that's compensating for lack of either salt or some of the other nutrients in the heart. So sometimes in your calcium channel movement, there's an excess amount of calcium that might be found in the heart. It's usually asymptomatic. When it is bothersome, then you'll probably be giving some kind of salt tablets or something to try to induce the exchange between the salt and the calcium, but it's not usually that bothersome. Okay. So you have coronary artery disease, angina, that's the recurrent chest pain, like from minor exercise. Myocardial infarction, that's your heart attack. Cerebral vascular diseases, such as stroke. Stroke, I'm not going to mention a lot because that right there is like a 2-day topic also. But it is part of this whole thing. And I don't know if anyone's ever heard of a TIA. Has anyone ever heard of a TIA? See, yes. And TIAs, a lot of people take them not as seriously as strokes sometimes. Yeah, yes, you should. Because they're like, oh, well, you know, it's not a stroke. But that is like your wake-up call. That is God saying you need to change what you're doing right now because you're going to have a stroke. You had a question?
What exactly is that?
Transischemic attack. So that's like a precursor, like a preliminary little rupture right there where you might like blank out for a minute, lose consciousness or what have you. Sure. Mm-hmm.
Wait, hold on.
A few months ago.
Mm-hmm, mm-hmm.
I was simply watching on Sunday, watching a football game, and I got up to go into the kitchen to make something to eat, and suddenly I felt that my lip on the right-hand side got numb, then my fingers got numb, and my foot got numb. And I recognized it right away. I mean, I know enough about a lot of things to recognize it right away. I didn't know the terminology, but I recognized it right away as the beginning of a stroke. And so it only lasted maybe 2 minutes. It was really, really quick. So I called a cab and I got myself to St. Luke's Hospital right away. They took me in and into the emergency room, did some tests, you know, motion tests or whatever it was, and they kept me, and then they did all of the testing that night. But as she just said, it was the wake-up call. So I went to my primary care physician right after that, and you know, had a whole battery of tests. It didn't leave any scarring on the brain, although I know someone just recently, a relative of mine, had a full-fledged stroke that left the, you know, marks on the brain. But again, it was a wake-up call, so they put me on the aspirin thing, and I guess I'll be doing that the rest of my life. But I mean, I was already taking care of myself pretty much, you know, beyond that, but I guess I'm at an age where, I don't know. But anyway, I do exercise and all of that, but it put me on notice. And, you know, the fear of this happening again makes me make sure that I'm going to do everything I possibly can not to have it. And again, it was very mild, but everything went numb. The lips went numb on the right side, the fingers went numb, and the foot went numb. And I just had enough sense to know what this was, and let me do something really, really quickly. So I was in the hospital. Everybody here in my office knows, you remember, I was in the hospital for a few days. They kept me there. They did all of the tests. They put me in the machine and all of that kind of stuff. And so basically that's what it was. But if you get it, you'll know it immediately now that you're having this lecture, if you didn't know it before, because it's nothing to play around with. And I plan on not having one again.
Yes.
Hold on. We need this for online.
Does a silent heart attack, does it do the same damage as a regular heart attack would?
By silent, you might mean...
A silent stroke, maybe? I mean, I don't know.
Well, they're all pretty silent. There are some heart attacks that are less severe than others. And so when you do have them, they keep you in the hospital for observation and give you anticoagulants, which make the blood flow easily throughout your vessels to make sure that you don't have a second heart attack. So if it's mild, like Dr. Conyers just said, if it's a mild stroke or a mild heart attack, you are susceptible, or you are under watch, and this is your notice that the big one might be coming.
Yeah, that's what happened to my mom. They she went in, she felt the same thing Dr. Conyers felt, numbness.
Yes.
And then she said she couldn't, for like a minute or two, she can't remember what happened. And then a week or two later, she went to the hospital because something was bothering her in her chest. And they said that she had just had pretty much a heart attack, but because they can see it in the heart.
The EKG,
yeah. And then, but she's okay now, and
thank God.
yeah.
So. But that was the warning. Yeah. No. Exactly. Yes. And that's also a warning to you, because that means that it's in the family.
My grandfather, her dad passed away with heart attack, so it is in the family. All right, thank you.
You're very welcome. Thank you. So some of the things that happen due to atherosclerosis: the stroke, the TIA, the peripheral artery disease, that causes the pain with walking or at rest, poor wound healing. Always pay attention to poor wound healing, because that means something is going on. The body is a well-oiled instrument. In any setting, if you find that a wound is not healing correctly, something is going on. Whether it be diabetes, whether it be atherosclerosis, something is wrong. Amputations due to the peripheral artery disease. If you have decreased blood flow to your toes, then the nutrients that the toes are going to need are not going to be provided. The feet, toes, slowly but surely get amputated. That's what happens in diabetes. Slowly and surely, you know, the toes, the foot, the leg, if you're not taking care of yourself. Who gets atherosclerosis? Nearly everyone. The risk of developing serious atherosclerosis increases with age. So the older you are, the more likely you might develop atherosclerosis. Does it mean it's going to be severe? No, not necessarily. That's why I showed you the different cross-sections where you saw the mild versus the more severe. The disease process begins early. Studies demonstrate evidence of plaque presence in hearts of people as young as 17. So people think, you know, oh no, I'm young, I can eat whatever I want. It's always good to start early. I mean, when I have like patients that say, oh, it's so hard to stop eating this way, and they're like 40, 50, 60 years old, I'm like, you have been eating this way for a good long time. You've enjoyed it, so now it's time to stop, in order to reverse the process, because the body can start to try to help heal itself. It's like smoking. If you stop smoking, the lungs will start to get better. Risk factors for atherosclerosis. How fitting. Smoking. If you're smoking, stop it. Nothing else to say about that. High cholesterol. High blood pressure, which we'll be talking about next. Diabetes, which is my last topic. Abdominal obesity. That means that spare tire. It's not only not cute, it's not good. So exercise helps. Stress. We have to learn how to de-stress, especially this community, especially with everything that we have going on. Exercise helps. Meditation helps. Reading helps. Just getting into a quiet space helps. Not eating fruits and vegetables. We must eat fruits and vegetables. What did I say? What did I just say? Thank you. You weren't listening. Excess alcohol intake. More than one drink for women, 1 or 2 drinks for men per day will put you at risk for atherosclerosis. Not exercising regularly. I mean, you're going to see a trend here. Exercise and healthy eating, I mean, it's not just to make you look good. It actually keeps you around longer. Heart attack, which is what the young lady in the back just spoke of. And basically, it's just the deprivation of oxygen to the muscles of the heart. And like I said, the arteries are the last blood supply to the heart. If they're not able to supply the heart, then the muscle starts dying, and that's when you get a heart attack. And if you speak to anyone that has had a heart attack, it is like, I forget, a lot of people say it's like an elephant sitting on your chest. It's just a crushing event. It is a massive, massive event. A lot of times I'm just so taken aback at the, you know, the nonchalance at a lot of these disease states because they become so regular in our community. You know, people are like, yeah, I have the sugar and I have, you know, high blood pressure. These are not things to be played around with. They are a lot of the reasons why our insurance and hospitalization prices have increased, because we are in the hospital all the time because of these. And these are preventable disease states. We have to get into the practice of practicing preventive medicine. I don't want to be treating you when this is happening. Let's, you know, start dating each other when it's like this, so that we can prevent this. Symptoms of a heart attack: left-sided arm and chest pain, chest pressure, syncope, which is loss of consciousness, nausea, vomiting, upset stomach, sweating, and anxiety. So once this happens, this is the mode of medical emergency care. The first thing they'll give you is morphine, because like I said, a heart attack hurts. Oxygen, to try to get some of that oxygen to the place that is being damaged due to lack of oxygen. The nitrogen, nitrate tablets, aspirin, of course, to help with the blood flow. Cardiac catheterization if the blockage is still there. So that's going in with stents and opening up the blockage. Anticoagulation medication. That's medication given to stop these little blockages, to diffuse the blockages. Late complications of heart attack: heart failure. That's just when the heart is so damaged it's not working correctly. And arrhythmias. Most times you can see on an EKG that someone has had a heart attack because an arrhythmia is one of the lasting effects. How to prevent this: quit smoking, eat low cholesterol foods, exercise. Same things that I repeated on the last slide. Please take your medications. Please, please, please take your medications. If you find the medications are too expensive, always ask the doctors for samples. They get loads of them from the pharmaceutical companies. Also, ask for a generic brand. But don't not take your medication. Goal to lower HDL and raise HDL levels. 3 ways to lower cholesterol: diet. Did you have a question?
It was just prior. I was going to ask, the cholesterol and high blood pressure, does that run hand in hand, or can you have a low blood pressure or high cholesterol or high cholesterol?
You can have either or, but having one makes you more susceptible to developing the other.
Okay.
Cholesterol lowering medications such as the statins. You've seen the Lipitor, the Zocor. Yes. Herbs? If you're seeing a holistic doctor, and they said that is what they're giving you for that treatment, I'm not too well versed with holistic medicine, and it's working, I'm not against it. I will just tell you not to take it in conjunction with the medication that a MD gives you, because if they're giving you something to lower your blood pressure and then you're taking a tablet to lower your blood pressure, then you can bottom out. But make sure that you tell your holistic doctor and your medical doctor what you're taking. Yes.
The last time I read anything in AMA, the science said that there was no definitive information or definitive study to show that holistic medicine actually works depending on the department. How would someone know that holistic medicine is working, and how would they know it's not an actual placebo effect as compared to something else? You're saying, take your medication. There are a huge number of people in our community who are going into a whole host of things that have not necessarily been definitively shown to work. And that includes, to some degree, acupuncture. So that's my question. I mean, again, a placebo effect, can make you feel like
you're getting better.
Exactly. You may not actually be getting better.
Placebo effect will also not last long.
Yeah.
That's how you'll know.
Yeah.
So I mean, if you're being followed by your regular physician, they'll monitor you. Okay, it's working. Okay, let's see. Okay, and then whoop, your blood pressure just went up. So we're going to take another reading in a couple weeks and see if this is still working. Oh, it's still up. It's not working. I'm going to give you one more appointment, and if it's not working, then we're going to have to go to traditional meds.
The reason I'm raising it is quite often people get caught in
Oh, yes. Oh, yes. Oh, yeah. Uh-huh. Mm-hmm. Yeah, yes. Of course. Mm-hmm. Yes, it does happen in our community quite often, and, you know, sometimes you get into arguments with people, you know, that are well-versed in herbology and holistic medicine, but if it's not working, it's not working. We have the medications to work, so use those. You okay?
No, I'm
okay.
off.
Everyone okay so far? All right. Then you have the niacin is another medication, bile acid resins, and fibric acid derivatives. Fiber is very important when combating high cholesterol treatment. In the beginning, when you might see that you have the inklings of hypercholesterolemia, I know a few friends that went on the oatmeal diet, so to speak, implemented oatmeal, Metamucil helps, the skin of fruits, apples, vegetables, leafy, dark leafy greens. Increasing those help a lot. If you are very serious about trying not to be on the medication and you want to make a executive decision to go and change your diet and exercise, your doctor should be behind that, but you have to be serious. Just don't use it as, you know, something to delay your medication.
What about juicing?
Juicing? Everything in moderation. It has to be done properly. I don't have anything against juicing. I like juicing.
Just in reference to the dark leafy
greens, yes.
because I know at times you can juice them. It's been said it's better to actually drink it than to consume it. So, I mean, that was just a question overall, maybe.
You still need fiber.
Yes.
You know, and you hear that from, like, say someone like on TV when the juice man used to juice and he says you get 100% of all of the nutrients from juicing, implying that you don't get 100% from eating it.
Yes,
You
yes.
still get 100%.
It
You still need to have the fiber.
Exactly. So it depends on what your machine is taking out.
Exactly.
If it's taken out, you know, everything and just left you, like, say, for instance, you put some kale in there and you find just like half a stem in your juice, then that's not good. It depends on what's left. Like if it takes out all of the, you know, the fibrous pulp or whatever out of the fruit or the vegetable, then that's not what you need. If all of the good stuff is left out in the machine, then you're just getting juice that you could have bought at the store.
And actually, you're supposed to, you know, technically, once you juice all of the remains of the fiber, you're really supposed to make a quiche or something out of it. You know,
Yes.
you're not supposed to really throw it away.
Yes.
Most people do, but you're supposed to do something. There are recipes where you, you know, you're getting that too.
You had a question? No. Okay. Okay, sorry. I'm not going to look that way anymore. Just kidding. Atherosclerosis treatment, preventing heart attack, lifestyle changes. We've already gone in on that. Medication, invasive techniques such as angioplasty. That's inserting a balloon via stent into and moving the blockage along. Stenting, that's putting in permanent structures to open up the vessels. Coronary artery bypass surgery, that's the surgery. Depending on how many arteries you have blocked, it could be ×4. I think President Clinton had ×4 in New York Presbyterian. So heart disease, which we've gone through, is a broad term for conditions that affect all of us. Many of the diseases, if left untreated, can lead to heart attack. They are preventable, and I will continue to harp on that. A lot of these diseases are preventable. I did say in the beginning that I'd be talking about fast facts, and like I said, I don't really go into charts much. But here are some fast facts from the New England Journal of Medicine. Researchers have found that African Americans have a higher incidence of heart failure than other races, and it develops at younger ages. Heart failure means that the heart isn't able to pump well as it should. Before age 50, African Americans' heart failure rate is 20 times higher than that of whites, according to the study. 4 risk factors are the strongest predictors of heart failure. High blood pressure, which we will be talking about next. Chronic kidney disease. Chronic kidney disease is killing us, and that runs in conjunction with diabetes. 3/4, and having low levels of HDL. the good cholesterol. 3/4 of African Americans who develop heart failure have high blood pressure by age 40, and that's relatively young. Black Americans and heart disease. Black Americans are at great risk for cardiovascular disease and stroke than our counterparts. Black women 49% and black men 44% have higher rates of heart disease than white men, 37% for white men and 32% for white women, between the ages of 45 and 64. Now that's not old. Black men have a 70% higher risk and black women have a 50% greater risk of developing heart failure where the heart is not working well at all than white men and women. The earlier onset of heart failure means higher rates of hospitalization, earlier disability, and higher rates of premature deaths, such as strokes and heart attacks. And that's why we're dying out here. One of the reasons why we're dying out here. Especially the incidence of first strokes is much younger than our counterparts. We have people having first strokes in their 20s. And like I said, it's preventable. Please, please, if there's anything that you do take away from this lecture, make sure that you see your primary care physician.
Let's break that down.
Sure.
You said in terms of the African American population, the African American population is only one section of the overall African population.
Yes.
So in comparison to African Haitians, African Jamaicans, African whatever it is, continental Africans, what is the relationship between what African Americans are suffering from in terms of, yes, diet, food, whatever it is, in comparison to the overall African population, as far as you know?
Well, they've been saying they haven't been seeing that much difference as of late because of the westernization of these countries and the implementation of fast food and processed food in these countries. So it's not as different as it used to be.
Right. So the gap is closing
Yes.
because of that.
Yes.
Just real quick. So, is there a link because in terms of like diet of maybe like our ancestors versus like in comparison to maybe our body types and the way that we consume food and the like. For instance, I know a lot of West African people that come from that West African area often might eat a lot of like yams and stuff like that, or high carbohydrates. But they were able to kind of like burn a lot of that stuff off because of, you know, farm work and less sedentary work. So I was just wondering, does that have a correlation to high blood pressure?
In excess and how it's cooked. A lot of times we weren't using a lot of these processed salts and herbs and stuff that we're using now that have like thousands of milligrams of sodium, which contribute to all the stuff that we just spoke of now. They might be eating the same things, but it might be also the things that they're adding to it. Yeah, no, go ahead.
When we examine the remains and mummies of ancient Africans, especially in my expertise is Nile Valley civilization, like Egypt. When we look at those mummies, one of the things that we find in the mummy, we find most of the things that we find now, but we don't find it as the magnitude is not exactly the same. And it appears that part of the reason for that, and we can only speculate because we don't have that number of the population that we can find because it's mostly the wealthy. But what we do find is that quite often is because of the type of diet that people had. A lot of vegetables, especially among the populace, and along the Nile Valley and through Africa in general, meat and other high whatever foods were confined to the very wealthy.
Yes.
You know, and so even when we see most of tooth decay in ancient Egypt was among the wealthy who could have meat and so on and so forth. Most of the people whose teeth went bad was because that there would be sand that would get into the food. You know, because you're living in a desert country, sand would grind the teeth down.
Yes.
So when we look at ancient Africa, all over the place, not just in the Nile Valley, since I study all over the place, that we find that because of the kind of diet that people had, when we do find these remains, we can suggest and infer from the numbers of the remains that we do find when we find them, we can presuppose that diet had a lot to do. I mean, people sure still died. They,
Yes,
died
of course.
From, from all kinds of things. But we can infer from that, when we examine the interior of the body, that they weren't suffering necessarily from many of the things that we now are accustomed to in the Western world.
Too many shortcuts right now with how we cook things. Right. We don't make our own herbs. We don't make our own sauces. So just grab the sauce from the top, grab the little herb packet, which has like 2,000 milligrams of sodium, and the sauce, which has about 1,000, and then, that's a heart attack right there. Yes?
Yeah, I was going to talk about that kind of. For example, like my first actual nutrition class probably wasn't up until like the point that, maybe like 2013, when I graduated from a community college. And I was so shocked once you take a nutrition class, what you're actually consuming.
Yes.
Because I feel like in the African American community, they don't really break a lot of things down for you. And I know growing up, I thought I was having vegetables, but a lot of my vegetables, honestly, were from a can, and my mom really didn't cook that much. And so I grew up in a family where you have, like, obesity, until you realize, like, oh, my God, I really am slowly on the track to killing myself.
Yes.
Because you have no idea really what you're consuming and what's good for you and what's bad for you. So I was just wondering, like, especially in 2016, because a lot of people do have this knowledge, are the numbers kind of changing, or are we still rising for these risk factors?
The thing is, and I was going to touch on that later on, but we can talk about that now. A lot of people think it's expensive to eat healthy. And that's a fallacy. I have a good friend that's a nutritionist, and she'll sit up and tell you in her West Indian voice, that's a lie. You can buy fruits and vegetables at Aldi and eat them and eat well. Shop within season. Buy the blueberries when they're in season. Buy the strawberries when they're in season. Cook fresh foods. Meal prepping is not just for weightlifters. The more often that you cook, the less likely that you're going to be outside eating any of these foods. Okay? Make your herbs. Make your food. Shop at open air markets. Walk past the Burger King, walk past the Wendy's on your way to the fresh food markets. I mean, it doesn't cost more to eat healthy. Yes.
I want to know how much exercise is like the right amount of exercise, because
I'm a dance teacher, so I kind of just chomp it up to my exercise, but I don't know if I can do that, if that's considered enough exercise from.
How often do you teach?
I teach 3 times a week for like 2 hours, 3 hours.
Okay, it depends on what you're trying to do. One would say you would want to exercise about 4 to 5 days a week. And as we're getting older, one would want to implement some kind of weightlifting, especially with women, some kind of lifting of weights or resistance training for your bones. So you don't develop as quickly osteoporosis as some of our other counterparts develop. And it also depends on your diet. So you can out-eat your 3 days of, 2 hours of exercise. There's a lot of people that exercise, 5 to 6 times a day, but they eat terribly. But, it'll still show. You'll wonder, oh, my God, why don't they have a six-pack? It's because they're not eating six-pack food. Like they say, abs are made in the kitchen.
I have a question about osteoporosis.
Yes.
In biology and in physical anthropology, we have been taught for a long period of time, and we're still being taught in physical anthropology, and that's what I do, that osteoporosis was mostly, it afflicts everybody, but it was mostly a disease that afflicts women of European ancestry, Caucasian women, and Asian women, and to a lesser degree, African people. Has that percentage of African people increased in terms of osteoporosis? I mean, are there more of us, men and women, who get, you see people in the community?
Yes.
Is that percentage rising in comparison to the Asian population and the European population?
Yes, it's increasing because we're intermingling, one. We're not in the sun like we used to. That's what helped us process our vitamin D. And we're not eating properly. So it is increasing. Any other questions? Yes.
Yes. I eat a lot of cooked food, and I was wondering, is there a lot of pesticides in the food? Because I was wondering if you can have like organic food to eat the cooked food.
Okay. You were gonna say?
You know, nowadays when we talk about it, I just recently read a study, and I wasn't doing it for this. You know, I study everything. Recently read a study that there's virtually almost no difference between what we call an organically grown without pesticides and that which is using pesticides. The planet in and of itself, number one, just living on the planet, you get a certain amount of radiation from the planet itself. You get a certain amount of pollutants from the planet in and of itself. That's a hard question to really deal with. There are people who are organic nuts and say, well, you know, this, and if you believe that 100%, it's the same thing with the placebo effect. You can't argue that. For instance, people are arguing that there's a difference between sea salt and table salt. I don't know if any difference between the two, and the reports that I've read suggest there is no difference between the two. But people will have argued me down on that. So again, that's a very hard, it seems to fall in an area of what people believe and don't believe and all of that other kind of stuff, the placebo effect. If I'm feeling good for a while, then it's working. If I don't feel good, then there's something else. So, you know, I really don't, you probably have a better answer for that than I do. I really don't know how to answer that question. You know? I
pretty much would have said the same thing that you said. Yeah. So, it's perception, fad. Yes.
But I have, go ahead.
Yeah. Your conversation, well, your lecture is very interesting, and for me being aspiring to be a doctor as well, I have to leave now, but I was wondering if I could get your contact information. You have a card on you?
Yes. Okay, yes.
Okay.
You're here at the school, right?
Yes, I'll leave my information.
Okay, thanks.
Thank you for attending.
I just have a question.
Yes.
How do we get in the habit of like connecting the foods that we eat on a daily basis with potential diseases? Because I feel very disconnected from the meals that I have on every day. So what would you suggest are ways to improve that?
When you say disconnected, what do you mean?
Like I would, like for example, if I'm going out to eat or something like that, I'm not thinking about what this is doing to my body, like eating a cheeseburger or something like that. I know that it's bad for me, but then, at that moment, I'm like, okay, I'm just going to have this meal and I'll be all right. And then it happens the next day and the next day. So how do you get in the habit of not doing that?
Are you exercising?
Not regularly.
If you were exercising and meditating, you would get more in tune with your body. Because you would see what the effects of what exercising and increased water intake would do for your body. And then after exercising, go eat like a triple burger or what have you, and you would immediately feel like how it feels, especially when you start eating healthy. Like try like taking away a lot of the unhealthy things, whether it be like one snack a day or what have you, and the next week reintroduce that snack and see how your body reacts to it.
Okay, thank you.
Also, to kind of answer her question, me and myself, I had to lose my doctor told me I had to lose about 30 pounds over the last year. And so I worked and worked and worked, and then I actually did lose the 30 pounds. And I'm trying to keep going, but I think you realize that when you start to work out, you honestly do start to feel good about yourself. And I realized that I'll get up, I used to get up maybe like 7 o'clock in the morning, and then I changed my habit to get up at 5. And then I realized that, by getting up early, eating an earlier breakfast, I really do start to feel good about myself. And then your habits just change over time because you kind of just make up your mind that you just want to be different. You want to be better. And then I realized that when I actually would take a break from eating a fast food and I would go back to eating like a fast food just once in a while, I honestly felt so sick because my body hasn't had that type of grease in so long. So I think it really is just a habit, and it's just making up your mind that you definitely want to live a healthier lifestyle. And then you honestly just don't miss it after a while. So.
I have one other thing I want to ask you a question about before you get into this.
Sure.
We're in the era now of Franken food. it's no way out of that. It's just about everything that we can purchase in a supermarket or any place else for that matter. I mean, it's the proliferation is all over the place of frankenfoods. What do you think? And again, I've been reading these studies. What do you think may be the long-term effects of having a pig's genes inside of a tomato for preservation? And I know what you're going to say, but I just want to hear it. What do you think may be the possible long-term effects of this era of frankenfoods that we're in now? Frankenfoods are genetically modified foods. So just your prognosis on that.
You're going to see an increase of what we've been seeing. Yeah. You're going to see little girls developing at 8, 7 years old where they should have been developing at 12 years old. You're going to see increased rates of cancer, which we've been seeing, or increased rates of other like diseases that we thought we eradicated that suddenly are on the comeback. Decreased immunity, a bevy of things. Yes.
Just in terms of, I guess, talking about the heart, like when you do these surgeries, they're usually open heart, right?
CABG, yes.
I'm assuming. Okay.
Okay. Just a quick overview of hypertension, aka high blood pressure. Definition is the force of your blood pushing against the arteries, the walls of your arteries. Your blood pressure is highest when it's pumping blood, and it's lowest when it's in between beats. So at its highest, that's when you'll hear the first lub when you're listening with the blood pressure cuff, and that's called the systolic number. The second sound that you hear, we usually say lub dub, or the second bump, is the diastolic number. What we're searching for, the numbers have changed in recent years. It used to be ideal to be 100 and for your blood pressure to be 120 over 80. Now we're looking for 110 over 70. We consider 120 over 80 to 139 over 89 as pre-hypertensive. So we're looking for the lower number. We're looking for a 110 over 70 to 119 over 79. Pre-hypertension means you might end up with blood pressure, high blood pressure, if you don't do something to prevent it. Yes.
I'm sorry, what was the low end of that spectrum that you just mentioned?
110 over 70 to 119 over 79. That's ideal. 120 over 80 and up, 120 over 80 to 139 over 89 is considered pre-hypertensive.
So 120 over 74 is not that bad, is it?
120 over 74?
Yeah.
I would look to see about decreasing the top number. You would be considered pre-hypertensive. It's virtually asymptomatic. In few cases, you'll have people say that they've had headaches, they've had nosebleeds, they've had a stiff neck, but they've let it go on so long that they just thought it was, they just attributed it to something else. And a lot of times they might have something else going on with them, so it's not directly attributed to hypertension. There are two types of high blood pressure. It's essential, which is the first type, and that just develops with no reasoning. It might be genetic, familial history. Then there's secondary, which is caused by underlying conditions such as obstructive sleep apnea, kidney problems, adrenal gland tumors, thyroid problems, medications such as your over-the-counter pain medications may increase your blood pressure, your birth control pills, if you're using illicit drugs such as cocaine or amphetamines. That's why a lot of times people that use those in excess end up with heart attacks. Okay. Alcohol abuse. You'll find that's a common thread anywhere. Excess alcohol is just not good for you. Risk factors. Age, early middle age, or about age 45 for men. And I just found that so interesting that they consider early middle age 45. Like the numbers just keep decreasing, decreasing. But I guess it's because we're living a lot longer as well. And age 65 for women. Race, it's particularly common amongst our community and develops earlier in our community as opposed to other communities. Family history plays a part. overweight or obese, not active, tobacco usage, too much salt in diet, too little potassium in diet, too little vitamin D, and again, drinking too much alcohol. Complications. That can lead to heart attack or stroke. Well, we've spoken about that. Aneurysm, heart failure, weakened blood vessels in the kidneys. The kidneys and the heart, they are really good friends. You have to protect both of them. If one of them goes, chances are the other one is going to go. Thickened or narrow blood vessels in the eyes. The eyes are very sensitive to anything that's going on with the blood because they're very vascular. Metabolic syndrome, and that's when you have an increased waist circumference, so your waist is a little thick in comparison to what it should be. High triglycerides, which is the high fatty acids, low HDLs, which we've spoken about before, hypertension, and high insulin. So that's the whole spectrum that's running together. They call it metabolic syndrome. Impaired memory is also found with people that have high blood pressure. So we'll talk about preparing for your appointment, tests, and diagnoses in just a moment. Myths and facts. Is there a higher prevalence in the African American community? Yes. Is there some racism? Is there genetics or physiological conditions that give us a predisposition? And I think you might have asked about that earlier. And I think in 2007, Dr. Oz came under fire for making reference to a, what is it called, the slave hypothesis that has been taught to doctors in his era that still continue to teach young doctors like myself and even younger doctors that all of the slaves that went through the Middle Passage were able to maintain their salt storage due to malnutrition and lack of hydration, and that's why they were able to survive the Middle Passage. And we and we are the the descendants of these stronger slaves, and so that's why we have high blood pressure. And the reason why this is hogwash is because how are we going to test that theory? I mean, I'm sure we're not going to find any Africans that are going to get on a boat and go through the Middle Passage in order for us to find out. So it has not been demonstrated and it has not been proven. It's just, that's not it. I will always go back to diet, exercise, and some of the other stuff. Yes?
Do you know why, like, what's that related to, that misinformation? Is that like, I mean, I've heard of like eugenics and like the science, kind of like that whole science. Mm-hmm. Like, was that ever introduced in terms of having care for people of African American descent?
A lot of times, some doctors don't have a high population of African Americans that they see. And if they haven't grown up in areas in which they come into contact with a lot of African Americans, they're not going to know how to treat them. They're not going to know how to understand some of the names that they have for some of the disease states, like my pressure, or my, I have sugar, or, fleas bite us. I have dropsies for narcolepsy. I mean, they write down this stuff and then they come in and they're like, I don't know what, they're saying or what have you. But they get immersed a lot of times when they're trained in some of the inner city hospitals. So if you're training, like I trained at Grady, and you have your Emory students coming in, they can't necessarily relate to a lot of the patient population, but they learn quickly because we're demanding that you learn how to take care of your patient population if that's what you want to do. Yes.
The idea of eugenics, even before the term was used, has always played some part, directly or indirectly, in terms of understanding African people from a medical point or any other point.
Yes.
We had Harriet Washington here, a good friend of mine who wrote the book Medical Apartheid. But even had we not had her there, here, it's always played a part. If you look at some of the well-known personalities in the world, and I'm not necessarily have to even mention what went on in Nazi Germany with the black population in Nazi Germany. We're not just talking about the gypsies and the Jews. We're talking about the blacks in Nazi Germany during that time. If you look at some of the well-known personalities, here in the United States, including one of the main founders of the AMA, whose statue is right outside on Museum Row. I can't think of his name right now, it will come to me, on Museum Row, who played a part in this whole idea. Charles Lindbergh, Edgar Rice Burroughs, these were all eugenicists, all right? And so this notion, even before that terminology was in popular usage, always played a part in terms of understanding the African person, the African population, as even a dispensable population.
Yes.
Remember, experimentations on African women, because it was believed, of African people in general, but African women in particular, because it was believed that African people did not feel the same pain that white people felt. And so the experiment in terms of women during the 19th century and earlier, the number of white women who would die in pregnancy, experimenting on African women. So this idea of eugenics, you know, the way it was applied in Nazi Germany and other places, always been a functional part of the thinking of this nation, even before the term was used. And still to some degree, just Dr. Oz here, and still to some degree, plays a role which has become very, very refined in the thinking, so that many people don't even think of it as being a racist notion, because racism can be both refined and unrefined. Most people identify the unrefined form, you know, the cop does something, this happens. But the unrefined notions that run through the strata of American history and American culture play a part in, even when people don't think about it. It even plays a part with us and how we think about ourselves. So it's there.
Yeah, because there are a lot of corrections that are still not have been made in a lot of the medical books. During my pathology rotation, the comparison of the bone structures. It's like, was anguloid, negroid, mongoloid. I'm like, what is this like? And I wasn't in school that long. I'm like, are you serious?
What was the name of the first president of the AMA? His statue's right out there on in Central Park Row. And he was notorious for this. I can't think of his name right now, and I know it so well. I can't think of his, he was notorious for this idea. So anyway, it'll come to me after this is over.
Yeah, so there are market disparities, disparities. But I have a lot of patients who have sought me out because, you know, being of African descent, they want somebody that looks like them. They want somebody to say, you know, what have you. I don't need to have a BMI of 0 in order to be, you know, healthy. You know, my waist to hip ratio doesn't have to be some ridiculous number, because that's not how we're built. You know, our bones are heavier. You know, we eat such and such, we process this way. There are market differences, but we don't have to act like there is one that's more superior than the other. For hypertension, I think, we've already gone through the nutritional and environmental with the foods and shopping. And the test and diagnosis is just the blood pressure cuff, just measuring it on more than one occasion. I think it's three separate visits, and checking and seeing if your diet, altering your salt intake, the DASH diet helps. Some people opt to take the blood pressure cuff home with them and mark down, you know, oh, it's higher here, it's lower there, or what have you, and monitoring it. But proper diet helps a great deal. Treatment, we are more prone to be responsive to hydrochlorothiazides, and some of the other drugs work a lot better for, like water pills work a lot better for us since we tend to retain salt. I don't really, I breaks my heart to see anyone under 20 on hypertensive meds because of the long run, you know.
So like in terms of tracking like your heart and stuff, like I have a Fitbit. Okay. So do you, like I was reading something about someone that said that their Fitbit actually helped to save their life or something like that. They went to the doctor, kind of maybe showed some of the results, and saw like we're able to do some preventative measures before something serious happened. In terms of like technology and now tracking, the thing, like for me, it's like I see what's on the Fitbit, but I don't necessarily know how to translate that. And it can do a variety of different things. And not to necessarily dismiss something like that, because I feel like it can be essential. especially if, like, you see something that's irregular. And my thing would be, what exactly would be an indicator? Maybe like an increase or decrease of heart rate, or maybe, I know for mine, it can kind of like tell when I'm sleeping, maybe sleeping irregularities and how long. So like my question would be like, what would be an indicator to you? I mean, since you do have one.
In this day and age, you can try to correlate your symptoms with what it's reading. Like if you feel like you're like out of breath and you just happen to walk to the stairs and you see that your heart rate is increased, then that's a problem. So you would write that down. Like if I were to try to track what's going on with my body, I would write that down. When I walked up said stairs, I walked up 5, stairs, my chest started hurting and I found out my heart rate increased markedly. Write that down and you tell your doctor. Does that help?
Yeah.
Okay. Like I said, you also take like blood work such as your cholesterol test, your urine analysis, and or your EKG if you find that the hypertension is asymptomatic. Here are some fast facts. The prevalence of high blood pressure in Black America is among the highest in the world and increasing. Rates are particularly high for Black women. In addition, Blacks develop high blood pressure earlier in life, and their average blood pressure numbers are much higher than our counterparts. As a result, Blacks have a 3 times greater rate of non-fatal stroke, but non-fatal stroke usually has detrimental effects such as paralysis or what have you. Just because it doesn't kill you doesn't mean it doesn't have effects. 8 times greater rate of fatal stroke, meaning that you will die from the stroke. A 1.5 times greater rate of death attributable to heart disease than whites, and Black Americans are 77% more likely than whites to be diagnosed with diabetes. And we'll go into that in just a moment. And Black and Hispanic adults are more likely to be inactive, 39.4%, 39.8%. So you see that there is a link in all of this. Activity, diet, all of that, all linked, and will only help to serve to make you feel better and keep you healthy. Diabetes. That's just a disease on how your body uses glucose. Glucose is your source of energy. It fuels your brain. When you're hungry, you can't think because you have decreased amount of glucose going to your brain. In order to understand insulin, you have to first understand how glucose is processed in the body. So our pancreas secretes the insulin that we need into the bloodstream. It goes throughout our circulation, which we've spoken about before, helping sugar into your cells. So then it lowers the sugar that's in your bloodstream. And then the sugar levels drop so that the secretion of insulin from your pancreas also drops. Okay? You need to also understand that sugar is the great source of all of the cells in your body. You need it. And it's the makeup of the muscles and the tissues. We get glucose from your food and your liver. Insulin helps sugar enter the cells into your body. With the help of insulin, your liver stores and makes glucose. When glucose levels are low, such as when you haven't eaten in a while, your liver breaks down stored glycogen. What it has in the liver is broken down into glucose to help your glucose levels stay normal. So symptoms, there are three different types of diabetes. Diabetes 1, diabetes 2, and gestational diabetes. Diabetes 1 is what we call juvenile diabetes. You're basically born with it or you develop it before adolescence. Diabetes 2 comes about after your pancreas just cannot make enough insulin for your body. Gestational diabetes is when the placenta starts producing hormones that just block off insulin, so it just stops working. Your risk factors: weight, we've heard that before, inactivity, family history, race, age. Gestational diabetes. If you're a woman and you're pregnant and you've had gestational diabetes, there is a chance that later on you're going to develop diabetes or you're going to stay with having diabetes after the pregnancy. Polycystic ovary syndrome. High blood pressure. Like I said, a lot of these diseases run together. Abnormal cholesterol. We've spoken about that too. Family history for gestational diabetes. Age, your weight. You have to control your weight no matter what people say when you're pregnant. Now, you can lead to gestational diabetes. Your test and diagnosis, the gold standard is the A1C blood test. That measures how your sugar binds to your blood for the past 3 months. And that tells you exactly if you're diabetic or not. Then you have your random blood sugar test, which is another blood test if that one's not available. Your fasting blood sugar test, and your oral glucose test, which they give to pregnant women, which is like the worst test known to man. You drink the nastiest sugary concoction after fasting for the evening, and then they measure your blood glucose within the next couple of hours. For type 1, you test your urine for your ketones. For children, it's very hard to figure out that they have diabetes. Check out for symptoms of excessive thirst, fatigue, irritability, things like that. Treatments depend on the type of diabetes. Healthy eating, if it's type 2, will help to revert the diabetes. Physical activity, monitoring your blood sugar, even if you're not on insulin, to make sure you see, yeah, I just ate this pasta at this time, my blood sugar spiked. I just ate these vegetables at this time, my blood sugar leveled off. Stuff like that will help you to control your blood sugar, and then you might not have to go on insulin therapy. Oral meds such as metformin if you do need to take medicine. A pancreas transplant, I'm sorry, I'm confusing that with the robotic pancreas, which is akin to a pancreas transplant, but it just pumps the amount of insulin that you need throughout the body at that present time. So you're not necessarily giving yourself the medication. The robotic pancreas is taking care of the insulin in the body. That's just recently become approved at 2013. Bariatric surgery if you're overweight. Losing weight helps a great deal. Long-term complications develop gradually. The longer you have diabetes and the less controlled it is, the more likely you're going to have complications, which include heart disease, nerve damage, which is neuropathy, kidney disease, we've spoken about that, eye damage, foot damage due to lack of circulation, skin conditions because you have impaired wound healing, hearing impairment, and possibly a link to Alzheimer's disease. So, for gestational diabetes, for the babies, you'll end up with maybe those 14-pounders that you've seen, and that's called macrosomia, and then that leads to, most people are not pushing out 14, 15-pound babies, so that leads to a C-section, low blood sugar, and then the child might end up with diabetes. For the mom, you'll end up maybe with preeclampsia along with the diabetes, which is increased high blood pressure, so you might have to be induced because you won't be able to sustain the baby with that elevated hypertension level. And subsequent gestational diabetes. If you've had gestational diabetes before, you might end up having it again. So here are the fast facts. Over 2.2 million African Americans have diabetes, and that's staggering. 1.5 million have been diagnosed. 730,000 are walking around undiagnosed. There are 4 times as many African Americans diagnosed with diabetes today as there were in 2008. For every 6 white Americans who have diabetes, 10 African Americans have the disease. Among African Americans 20 years and older, the prevalence of diabetes is 8.2% compared with 4.8% to your counterparts. Type 1 diabetes accounts for 5 to 10% for all cases among African Americans. But it is type 2 that is sending us to our graves early. It accounts for 90 to 95% of all cases. In every age group, the prevalence of diabetes is higher for African Americans, period. For women, it's higher. For men, it's higher. Among African Americans 20 years or older, 20, we're talking about young people such as yourselves, 11.8% of women and 8.5% of men have diabetes in your 20s. We're not talking about people in their 40s like myself. Nearly 1 out of 3 African Americans ages 65 to 74 has diabetes. Diabetes is particularly common around middle age and African American adults. This proportion has diabetes from less than 1% of those younger than 20 years of age, and as high as 32% for African American women. And what's that saying to us? It's that African American women are not as active as they need to be, not as active as our counterparts at all. I mean, I see it in the little, neighborhoods that I work in, our counterparts make it a must. I don't know if it's written in the prenups or what have you, whether they get up in the morning, drop the children off, 4 o'clock in the morning, 5 o'clock in the morning, they're at the gym, they're eating their little salads, they come back to come pick up their kids, they go get their massages. Everything that they do is for their wellness. We don't do that, and we need to start doing that. Death rates for people with diabetes are 27% higher for blacks compared with whites. Diabetes is the 5th leading cause for death for those ages 45 years or older. One of the problems for African Americans in diabetes is that they are more likely to develop diabetes complications. This is due to non-compliance. This is due to the expense of insulin that Bernie Sanders was speaking about. Insulin, which used to be like cents on the dollar, thanks to some companies, is outrageously expensive, considering it is the baseline medication for diabetes. The frequency of diabetic retinopathy. So many people are losing their vision due to diabetes. So many people are losing their limbs due to diabetes. So many people are on dialysis due to diabetes. And these are all of the complications. And we haven't even spoken about amputations. African Americans are more likely to undergo extremity amputations. The loss of your limbs, your feet, your legs, more than whites or Latinos. In 2014, there were 18,000 amputations among black people with diabetes, involving 155,000 days in the hospital. So what's the take-home message? The take-home message, if you see the common thread, is that we need to do better. We need to practice preventative medicine as opposed to what we're practicing now. We need to eat better. We need to take better care of ourselves. We need to de-stress. We need to exercise. That is the take-home message, if anything. If you don't remember any of the other stuff that, that I spoke about, you need to take care of yourselves. Thank you so much, everyone.
Well, thank you so much, Dr. Raqhael. For those of you who were here yesterday, I think you can see all of the connections to what Dr. Sharon Boyd Jackson talked about yesterday in terms of the psychological health and the intersection between psychological health and physical health, and as well as racism. And you can see those connections here a little bit today. In fact, a lot today. I wish I could have made some more comments about certain kinds of things, but maybe next time I will do that. Especially in terms of cultural relevance, in terms of why we do what we do. One of the hardest things to do in a culture is to change beliefs and attitudes. That is the hardest thing in any culture. Material things are often easy to do, but the cultural things that go way back, that have been there for hundreds of years, quite often are very, very difficult. And we're going to continue to explore this. We're going to have Dr. Raqhael come back at another point in time. I found this very informative, and just to know how the heart operates. And I want to ask the question, and of course, it may be a little bit beyond what she's talking about, but even in terms of how science is moving towards the idea of growing limbs from stem cells and others, and where we're at in terms of growing hearts. And I know there's been a lot of research, and I keep up on all of this. I keep telling people always, and I'm going to end with this, is that everything in the known universe is interrelated. And we have to learn something about everything. My field is history, primarily Egyptology, but I study everything so that I can become worldly and knowledgeable and act like I know something about everything. And I always recommend, those of you who take my class know that I say this in class all the time, learn something about everything, even things that seem to be apparently unrelated. You never know when you might use that information. So learn something about medicine, learn something about other sciences, learn something about history. It is incumbent upon you, especially in the world that we live in now, and especially with who we have at the helm right now, who's a danger, in my opinion, to everything. All right? You talk about not only in terms of the internal politic, but danger in terms of the idea of survival of human beings, in terms of environmental survival and everything else. So it's incumbent upon us to be knowledgeable, to be on point, to organize ourselves in every way that we possibly can, because the struggle has only begun. All right? The struggle's always been there, but it's begun again. Everything that you have right now, you can lose it very, very easily. Because remember, freedom is not free. Freedom requires something from you. So once again, let's thank Dr. Muriel Celestine-Raqhael for coming here today and sharing with us. And again, I'm really proud of her. I mean, she's a Kane alum. Her husband's a Kane alum. She's come back and she's given this information, and we're going to bring her back again. So thank you for coming out. Please come out tomorrow for Dr. Vanita Hambar, who's going to be doing something very, very special on the psychological health of African women. So if you're interested in that, please come out tomorrow. Now, David, do you have your phone camera? Because we didn't bring the office camera. I like those of you who are willing, come up on stage with Dr. Raqhael and myself and others, and we always take a group picture with our guests. We didn't do it yesterday because Sharon Boyd Jackson is a resident faculty member, but all of our guests, those of you who want to be in the picture, we take a picture up here, and it's a part of our archives and a part of our record, and quite often it goes into the newspapers, but even when it doesn't, it goes into our record of memory. So please come up, tell them outside to come in here, and once again, thank you for coming out. Even though there were only a few of us, I think you found this worth it. All right? Thank you so much. Once again, could we have a little bit of